quick, down and dirty. You've had everything that you need to know about neuro already. We're going to get the high points, the highlights. Your neuro lecture doesn't have the notes with it. I'll put the lecture notes out there after a while. There's a lot of good resource information on the neuro module, so please take a look at that. There's the podcast. There's a new visual thing that I've been playing with too, that creates kind of an overall broad picture of neuro. So I like that. Take a peek at that as well. There's some cranial nerves on there if you want to hit your cranial nerves. Probably not the most important thing for you, but they're out there for you if you want them. So take a look at that as well. See, there's a neuro study guide out there as well at the end that says after class resources. So take a look at those. Should get you ready for this exam. I also have to give credit to Dr. McCarty. Apparently she made this lecture and she got mad at me for putting my name on it. So she made it. Same last name, I didn't think it mattered, but apparently it matters. So. All the creative ideas were from her. But anyway. So, stroke of insight or neuro review. Big things we're going to talk about, cerebral vascular accidents, CVAs or strokes. We're going to talk a little bit about increased ICP, spinal cord injuries, traumatic brain injuries. We're going to have one or two slides on Parkinson's disease, multiple sclerosis, and myasthenia gravis, okay? And then just a hint of seizures as well. Okay? So very broad concepts here. Big things are going to be safety, communication, what kind of things I need to assess for my patients, what kind of discharge education, teaching can I get involved in with my patients, so I know that they're safe at home, any kind of follow-up visits and stuff that I might need for these types of patients. So let's get right on into it. Let's talk about cerebral vascular accidents. You'll hear them as CVAs, you'll also hear them as strokes. Remember when we're talking about strokes, we can break it down into two categories. We can talk about ischemic side of things. We can also talk about a hemorrhagic side of things. So with ischemic, remember there's some type of disease process. Maybe it's plaque buildup, atherosclerosis that's causing decreased perfusion in the vasculature within the brain. So that can lead to an ischemic event with your CVA, or we have some type of clot that travels to a certain part of the brain where it causes a decrease in that perfusion to that area. So we have that lack of blood flow. So our main goal with an ischemic stroke is to preserve as much brain tissue, as much brain function as possible. And so big things are going to be your fibrolytic therapy. Usually it's going to be that TPA, a clot buster, to get that clot broken up, to restore that perfusion to that part of the brain, to hopefully preserve or restore some of that brain functionality. Manage our BP, and then treat any complications due to that stroke. Any type of musculoskeletal weakness, paralysis, maybe some type of dysphagia that has occurred, or difficulty swallowing that has occurred. We need to get a swallow therapy or a speech therapy consult on there. Then we have our hemorrhagic side. So with hemorrhagic, we have bleeding, some type of hemorrhage that has occurred, and that's going to be that big difference between your ischemic side versus your hemorrhagic side. All right? Ischemic, think clot or plaque buildup. Hemorrhagic, think an increased amount of blood. With hemorrhagic, we have two separate subcategories. We have subarachnoid hemorrhage, and then we have an intracerebral hemorrhage. Subarachnoid hemorrhage, we have an increase or a large amount of bleeding within that subarachnoid space of that cranium that's causing pressure within the brain, leading to decreased perfusion, decrease in your motor response, your motor function, causing this big neuro type event. Your subarachnoid hemorrhages are going to be more of your emergent situations. We could have a large amount of bleeding that has occurred within this certain space, and that's subarachnoid space, right? So we're gonna have a sudden increase onset of a headache. We could have varying levels of consciousness, where we kind of go in and out of consciousness as well. And then our vital signs are gonna reflect that as well in the later stages, if this goes untreated. Big goals, kind of like our ischemic side right here, preserving as much neurofunction as possible, supporting our vital signs, make sure we don't have any rebleeding that's occurred, make sure we don't go into some type of neurogenic shock, treating our electrolytes, that kind of stuff. Our intracerebral hemorrhage is in the brain tissue space, so one of those blood vessels that supports the brain tissue specifically has ruptured. There's some type of bleeding that's occurred. Usually this is going to be a slower type of bleed from here, not quite as emergent as our subarachnoid hemorrhages, but still something that we need to take care of. This is really going to alter our tissue perfusion within our brain tissue and our brain function. Remember, with our hemorrhagic strokes, we have all this increased volume, all this increased blood, so that's really going to increase our endocranial pressure. So we're going to have a very high increase in our ICP. Overall, our signs and symptoms of stroke. Remember, our balance is going to be off. We might have a change in our pupils and our eyesight. Of course, we're going to have some type of weakness on one side of the body or the other. Facial drooping, slurred speech, my priority nursing interventions for someone that comes in with a CVA in general, I got to figure out if they've had an ischemic or a hemorrhagic stroke, and that's going to do my plan of care for me. All right? So how can I tell if I've had an ischemic or a hemorrhagic stroke? CT scan, right? That's going to show if I have an active bleed within my cranium or within my skull. All right? If it shows a clot, no active bleeding, I can get TPA on board if necessary. If it shows that there's bleeding that has occurred, then I need to have maybe a craniotomy or some type of intervention where I go in and cauterize or put a clip in or a coil in to clot off that ruptured area to decrease that arterial bleeding. So that's why these hemorrhagic strokes are more of the emergent side of things. Okay. After I've decided on what side I'm on, ischemic versus hemorrhagic, that's, like I said, going to determine our plan of care of our nursing interventions. Remember, get you a baseline level of consciousness, LOC, before you start anything else. That's going to be kind of your number one indicator that something is changing, something is getting worse. Remember, your change in LOC is going to be kind of your most sensitive indicator. So above all things else, I'm probably going to get a LOC to kind of get a baseline of where I'm at. Frequent neuro assessments, do that NIH stroke scale to start with. That way I know kind of my baseline, and then if something changes. I'm going to do that frequently. So get a neuro assessment to start out with. If we suspect a CVA, get that CT scan. Going to start that thrombolytic therapy if it's indicated for an ischemic side. Then I'm going to monitor my vital signs, make sure I don't have any altered vital function, so I don't need blood pressure support, heart rate support, make sure my airway stays intact. So I'm going to monitor those vital signs for complications. Any other final complications that might occur later on, some type of neurodeficits, musculoskeletal deficits. And then more longer term care, I can get therapy involved. So I can get occupational therapy, I can get physical therapy involved. maybe speech therapy, social work to get them the necessary equipment that I need. And then discharge teaching at the end when they're finally ready to go home. They're gonna need a lot of education to kind of adjust to their new lifestyle, depending on how much of a deficit that has occurred. Okay. Questions about that? Okay. And so, kind of hard to see, but I got a little balloon pupil right here. We have huge bleed right through here. And we have a little bit of one right in this area. This is an echo with a clot on it. You may or may not play. Yep. You can kind of see the clot all around in there. I'm assuming these are all older people. Didn't ask that before. So. Really good chart overall for your ischemic strokes right here. My risk factors, what kind of things I'm thinking about. Remember that AFib, big indicator of potentially a stroke. Other history could be hyperlipidemia, hypertension, smoking risks, diabetes. When I initially come in, I'm going to do an NIH stroke scale. I'm going to do a full neuro assessment. What kind of neuro assessment tools am I going to do? What kind of things am I going to assess? Grip strength. Perla. Actually do Perla and not just say Perla. Maybe that's pupils equally round reactive to light and accommodation. The accommodation piece is on there too. What else? Speech. You can do swallowing function as well. You could also do musculoskeletal function. And then respiratory status as well. Remember your ABCs. They may not be able to obtain their airway. Of course, you're going to get your non-contrast CT, potentially an MRI. Make sure that it is an ischemic stroke and not a hemorrhagic stroke. All your signs and symptoms, we've kind of talked about that already, but they're there. The things I want to highlight too is your nursing interventions over here. So your fibrolytic therapy. Remember, I can't give this for a hemorrhagic stroke. We're going to have some really bad consequences if we give fibrolytic therapy and it's a hemorrhagic stroke. Right? This is going to really increase their risk for bleeding. With our TPA, or our fibrolytic therapy, it's got to be within 4.5 hours of initial symptoms or onset of symptoms. Anything over that is contraindicated. We're not going to give it. Anybody else have any thoughts of contraindications for TPA?
Surgery.
So recent surgeries, good. What else? History of bleeding, so like a history of a GI bleed.
Is there something in there about a history of recent MI?
Recent heart attacks, good.
What about medications like heparin and stuff like that?
Yep, so if they've had heparin or low molecular weight heparin, Lovenox, within 48 hours. If they have an existing aortic dissection, maybe they've had a subarachnoid hemorrhage in the past, and now it's an ischemic CVA instead. What about their platelet count? If their platelet count's low, should I give it?
No.
Probably not, so less than 10,000 on the platelet count. So we gotta take all these things into consideration before I just go in there and push this TPA. Okay? Remember, always your ABCs, protect your airway, administer O2 if needed. You may have to require some ventilator support, depending on the severity. Remember, we're gonna frequently assess our neuro assessment. I'm not gonna just do an initial neuro assessment and then forget about it. Might be every 15 minutes up to an hour, and then stretch it out every hour for so often, depending on your hospital policy. But these are gonna be very frequent in nature. Monitor for complications. These are gonna be some long-term effects in here as well. The initial shock is gonna be a lot to them, so we're gonna provide that comfort holding the hand, doing that therapeutic communication piece that some of us like, some of us don't like, but you're gonna put that in there as well. Rehab support and eventually discharge teaching, getting them back to as normal of a function of their ADLs as possible. Okay. Question for all of us. Mr. Thompson, a 64-year-old male with hypertension and AFib, a rise in the ED with sudden right-sided weakness, facial drooping, slurred speech. His wife reports that symptoms started 45 minutes ago while he was watching TV. Assessment data, BP 198 over 102. Heart rate is 96 beats per minute, irregularly irregular. Respiratory rate 22, O2 sat of 93 on room air. Blood glucose of 108. The provider is considering TPA or alteplase administration. So at this time, as the admitting nurse, what's going to be our priority actions in this situation? What type of key assessment findings are we going to find before we can safely give the TPA? So let's do immediate actions. First thing, they come in the room, what am I going to do? Get a history. Okay, we already kind of got a history, so I don't really need to worry about that.
A baseline LOC.
Baseline LOC, good neuro check. Okay, I like that. What else?
Oxygen.
Oxygen, because he's only on 93% on room air, so he needs a little bit of oxygen, right? Good.
So would you do oxygen first or an LOC and neuro check first?
I would do a LOC neuro change first. 93 is low, but not too bad. And then I can do oxygen administration. Something for the blood pressure. It's going to be high. Initially, we want to bring that down. We don't want to bring it down too fast.
You probably wanna make sure the provider orders the CT.
So provider orders a CT scan. I need that, right? Before I just go in and push that TPA. What up? CBC, labs, good, good. All good things. IV access, I'm probably gonna need that, right?
So this was a priority question.
Yeah, exactly, yeah.
You would do LOC first,
Then oxygen.
then cause the oxygen is low, but like you said, dangerous. So I'm guessing the LOC first, then I guess the IV.
Nope, oxygen, then IV.
LOC, oxygen, IV, and then blood pressure.
It throws me off doing the LOC before the oxygen. I'm like, I know that's right, but
Yeah, 93 is.
I know, but I just think.
Okay, so if he came in and the oxygen was 89, would you do the oxygen first and then the LOC?
Now we're playing kind of devil's advocate on that.
Because I got a feeling this is something like it's gonna be on the test.
Yeah, that's what I'm trying to sit here and do. Cause I'm used to oxygen first, so now I'm kinda like, what?
It's not gonna be that serious. You're gonna know what to do first.
But I thought if it was like you wouldn't assess first if there's a life-saving measure, so why would you do a neuro assessment first?
This isn't a life-saving measure because it's 93% on room air.
There's a lot of people that
We
prefer
have,
every
we
You're
have.
not talking about the blood pressure.
Yeah, we're, let's get back to, on the road here. All right, so remember before our TPA administration, confirmed time of symptom onset, so we started at, 45 minutes right there, okay?
We're already an hour in.
So about an hour in probably, give or take, so we're good on that. Remember, rule out any contraindications. Before I give my TPA, I gotta make sure I have some type of blood pressure support on board. I don't wanna give that TPA and then have increased blood pressure. What if he ruptures or hemorrhages in the process as well? Cause that could be a reason for hemorrhage, increased blood pressure. Then I have an ischemic stroke and a hemorrhagic stroke at the same time. That's pretty much death. Make sure your labs are stable as well. Main thing is I'm trying to differentiate between ischemic or hemorrhagic stroke before I administer my TPA.
I got a question.
Yeah.
In a situation like that, if they established that it was an ischemic stroke, would their blood pressure, what they gave for blood pressure change? Like would they go with a vasodilator versus a beta blocker or something like that, or?
Not usually, well. No, I'm probably gonna give some type of, usually like labetalol or like a hydralazine. So they'll probably start with hydralazine or clonidine, which are both vasodilators. And then I really don't need heart rate support because it was like 70 something. So I would probably go with more of a vasodilator than anything. But usually it doesn't really matter on ischemic versus hemorrhagic. It just,
I just didn't know if that
that's what
helped
we do
with,
blood pressure wise for that.
like the vasodilator would help with brain preservation or something.
I
I don't
no,
know.
not really. I like where your head's at.
Yeah.
Question 2, Miss Lee, 72-year-old, we're gonna go with female, presents with sudden severe headache, vomiting, and left-sided weakness. CT confirms intracerebral hemorrhage. Which interventions are appropriate for this patient at this time?
A, B,
I'm hearing A, prepare for possible surgical intervention, good.
D, E.
I hear B, keep head of the bed at 30 degrees. Why that?
For the ICP.
ICP.
For decrease in ICP, good. What about C?
No.
No, okay. Make them bleed more. D, strict blood pressure control.
Yes.
Yep, good. And then what about E?
Yes.
Yes.
Makes sense, right? Only thing I really can't give right now is TPA. Don't want to increase bleeding further. All right, questions about that? Good. All right. Patient with a left hemispheric ischemic stroke has dysphagia. Which nursing intervention should be implemented to help reduce aspiration risk? So here, A, place patient in hypothalamic during meals. That makes sense. What about B?
No.
No, not thin liquids. C,
Yes.
Yes.
perform swallow evaluation before intake. I like it. Provide small bites and allow extra time.
Yes.
Yep, okay. Even if they have to swallow a couple times before we get the next bite. And then position head forward during swallowing.
No.
Yes.
Wait, why?
To encourage it to go into the esophagus, not the trachea. Closes off your epiglottis. Okay. Questions about CVAs? Remember your nursing education, first thing you're gonna assess when I can and can't give TPA, that kind of stuff. All right, let's talk about TBI, or traumatic brain injuries. So either some type of blunt force trauma or penetrating trauma has occurred causing this traumatic brain injury. Usually it's gonna involve some type of MVC, usually it's maybe some type of sports injury, gunshot wound, maybe a suicide attempt. Every now and then a fall, those kinds of things. Mild TBI, you're gonna have your Glasgow Coma score of 13 to 15. You're gonna lose consciousness up to 15 minutes. Then you're gonna have to wake up and kind of have this lucid state. Remember for our GCS, what are we monitoring? What are the 3 components of a GCS?
Pupil response,
Pupil response, eye
Speech.
response,
speech,
speech,
and wrist.
motor response. Okay, good, good. Moving a little bit further, we have moderate, so you're gonna lose consciousness up to 6 hours. With our moderate, our biggest fear is that they're gonna go into a severe state of a traumatic brain injury. GCS 9 to 12, so we're having decreased function within our motor ability, within our speech. That's where these neuro assessment, frequent neuro checks, frequent checks of the level of consciousness are gonna come into play. We're gonna get a CT scan just to be safe, to make sure we don't have any type of intracerebral hemorrhage, no type of brain bleed that has occurred, and we're gonna monitor our ICP pretty frequently. Anybody remember our normal ICP?
15 to 20.
15 to 20, anything above 20 is when we're in concern, right? Okay. Then severe. Severe, our biggest worry, of course, is gonna be death. That's gonna be our most severe type. They're gonna need the most level of care at this point. We're gonna pretty much have to do full support for them. So airway, breathing, circulation is gonna really come into play here. They're gonna need a lot of ventilator support, vital sign support. GCS of 8 or less, greater than 6 hours of loss of consciousness. Frequent neuro assessments, make sure we have our hemodynamics in check, our vital signs in check, and frequent CT scans as well. Remember, they can kind of fluctuate between any of those. So they go mild, moderate to severe. Usually we're going to increase. TBIs, we have primary source of injury. This is going to be kind of that immediate impact, the initial response to the traumatic brain injury or event. So that initial vehicle crash, that initial gunshot wound, that initial fall is going to be that primary source of injury. Common things: hemorrhaging, lacerations, contusions, kind of throw concussions in there as well. Based off of what happens in the primary source of injury, can lead to secondary injury causes. As part of that biochemical trauma response within that intracellular response. So if it cuts off blood flow, I have frequent seizures, ischemic event, causing that hypotension, kind of those neurogenic shock type of symptoms that occur, that's going to be a secondary source of injury. So normal ICP 10 to 15, we'll go up to 20. Anything lower than 20 is going to be a good thing for your trauma patients. Increased ICP, level of consciousness, most sensitive indicator. All right, I've said that a lot tonight. Of course, we're going to get our neuro status as well. So we're going to do a pupillary response. What type of motor function are they going to have? Are they able to follow commands? Are they able to squeeze my hands? Do they have good grip strength? Are they able to wiggle their toes? Move their legs appropriately as they should? We got headaches in there, projectile vomiting. I should say all through breathing patterns. So you'll have something like a Shane Stokes type of breathing, or the pregnant lady breathing, if you want to think about it that way. A Cushing's triad, remember, bradycardia, severe systolic hypertension, very elevated systolic pressure. The diastolic is going to stay the same, so you're going to have that wide impulse pressure with that. And bradypnea, or your low respiratory rate. The number one sign is going to be a change in LOC. All right. When we start getting further down these symptoms, down into the Cushing's triad, the posturing, that's going to be a very late sign of increased ICP. At this point, we're kind of too late. Things have already kind of taken place. All right. It's going to be more of an emergent situation the further we go down our signs and symptoms here. Okay. Ways to correct our ICP. So mannitol. Were we allowed to push mannitol?
No.
Yeah, we can. We push mannitol. Anybody remember mannitol?
Filter you.
It's an osmotic diuretic.
Osmotic diuretic, gotta have a filter with it. Remember, it's getting some of that extra cellular fluid within that cerebral space, causing a diuresis to occur, trying to decrease that ICP. Hypertonic saline, so real salty stuff, causing that fluid shift to occur between the cellular space and the intracellular space. Once I have the fluid shift occur, I can also absorb it, also diurese it out. So usually we're going to have some type of hypertonic saline on board and mannitol on board as well with that. Could also put in a ventriculostomy or a CFF drain as well. Any way possible to try to get all that volume out. That's what I'm trying to accomplish here. Now, other things we can do. Simple nursing interventions. This is gonna be kind of stuff that we can really get on board with and do pretty quickly. Increase the head of the bed. That makes sense, right? If I need to flatten out my patient, that's gonna cause that increased ICP to occur. All that fluid shift to kind of shift towards the head, all right? What about coughing? That's gonna increase my ICP, right? If I need to cough, only cough a little bit. If I need to suction them, less than 10 seconds. Give them a pretty good break before I continue. I don't want them to vagal down. So I can give like a stool softener, help with their bowels, so they don't have to strain so much. Blowing their nose, don't want to do that. All these little things that you can think about that's going to increase your ICP. You can also kind of think about it in a way of, if you ever everybody's had a sinus infection, I'm sure. All the things that hurt your head, hurt your nose, hurt your sinuses when you have a sinus infection, same concept. Okay? When you bend over, when you blow your nose, when you cough, when you're going to the bathroom, all those things, that's gonna increase your ICP. It's gonna hurt your head a little bit. Okay. Kind of a breakdown of what we just talked about. I would focus a lot on this nursing interventions box down here on this other side as well. Remember, I want to set them up as high as possible. Maintain their airway support as well. Maintain their vital sign support. Overall, trying to decrease that ICP. Questions about increased ICP? Okay. Cerebral hematomas. Remember, with cerebral hematomas, we can break it down into two different categories. We can break it down into epidural or subdural. And that's really where the location of the bleeding has occurred. So if we look at our picture down here at the bottom, if you look at A right here, the bleeding is happening between the skull and the dura mater right here. So that's gonna be your epidural side. And then B down here is happening between your brain tissue here and in the dura mater. So it's on the other side or other side of that layer right there. So B is gonna be your subdural hematoma. Epidural hematomas forms rapidly from arterial bleeding. You're gonna have a temporary loss of consciousness followed by a lucid period. Usually we're gonna have one dilated pupil kind of located on the same side of the injury that has occurred. Epidurals are real fast onset, fast occurring arterial bleed, gonna be a more of an emergent situation on your epidural side. Your subdural side is gonna be a venous bleed. This is a very slow moving, progressive type of bleed, usually. You can break it down even further into acute, subacute, and chronic, depending on when your symptoms present. So within 72 hours of the initial injury, it's gonna be your acute phase. Subacute phase, if you develop a bleed, a venous bleed, and then you have your chronic side. 21 days or more after that initial injury. of these again are gonna play a role in our changes in LOC and our neuro status. Okay, pretty cool picture. Epidural hematoma. And then we can kind of see it on the CT scan. So you gotta have your dura mater here. And then your skull, we have this bleeding that's occurred within the epidural space. And now we have evacuated all of that bleeding. That craniotomy. I like this picture, it's cool. 22-year-old patient is admitted after a motorcycle accident. He briefly lost consciousness at the scene, woke up and was alert, but now suddenly becomes lethargic and has a fixed, dilated right pupil. What is the nurse's priority action?
B.
I hear B. Anybody else have anything different? Nope, I like B. Okay. What type of injury is he experiencing?
Epidural hematoma.
An epidural hematoma. Good. Let's see. Briefly lost consciousness and then woke up as alert. So remember, a brief loss of consciousness followed by a lucid interval. I have that one fixed dilated pupil at the side of the injury, so on that right side. Remember, this is an emergency type of event. This is an arterial bleed. I don't need to wait another 15 minutes and see if he gets better or not. Gotta do some immediate intervention. All right, administer IV mannitol. That's not gonna do me a whole lot of good because I'm bleeding within my epidural space. Elevate the head of the bed. I like that, decrease ICP, but I need to prepare for emergency craniotomy. That's gonna be the thing that's gonna have my patient the most. All right. Patient with suspected intracerebral hematoma. What are the nursing priorities? So A, maintain my airway, good. B, monitor neurostatus and GCS closely. Remember, this is very frequent neuro assessments. Not gonna do one or two and then not worry about it. Even if that means that I'm not clustering my care. So if I cluster my care, then that means I'm not in that room frequently. Regardless, I need to be in that room frequently.
I think A, B, C. A, B, not C. D, D.
Yeah.
A, B, D, and E. I agree. All right. Administer anticoags to prevent further clots. I'm bleeding, so I don't need to administer anything else. Control blood pressure carefully, good. Prepare for possible ICP monitoring. Good. Patient is undergoing evacuation of an epidural hematoma. Post-operatively, which interventions are most appropriate?
A.
A, okay, good, I like that.
B.
B, monitor for drainage from incision, ear, nose, good. C, strict neuro checks, level of consciousness, pupils, GCS, good. E, keeps systolic BP control within ordered parameters, good. Remember, I'm not encouraging that vigorous coughing, that deep breathing. I'm not gonna do frequent suctioning if I have a ventilator in place, because that's gonna increase my ICP. Questions about hematomas? I know it's quick and fast, but we have plenty of time to review. Okay, let's move on to spinal cord injuries. So at some point or another, I've had an injury. Either it's a penetrating gunshot wound, maybe it's a motor vehicle accident that has caused either swelling or a complete severing of my spinal column, my spinal cord. That's occurred, so that's how I have my spinal cord injury. Remember, I gotta stabilize my spine. That's my number one thing right there. Put on that neck brace, put them on a backboard. Stabilize that area until I can further evaluate my spinal cord. Got your ABCs, maintain your patient airway. Extend that neck position. You're not gonna let them look left, right, move all around. Also things to think about with a spinal cord injury, assessment wise. So your cardiovascular care. Remember, I'm almost hyper-perfusing that area, so I don't want any hypotension to occur. So remember your neurogenic shock treatment plans. Increased fluids, right? Bolus fluids. I can also give a vasoconstrictor if I need to. Monitor some type of arrhythmias. Your bradycardia is going to be the most common, but you can have some other arrhythmias imbalances as well. Depending on the level of the injury, so if it's an upper level injury in your cervical column, you could require lifelong ventilation or respiratory type of support of some sort. Remember, with your frequent suctioning, less than 10 seconds, anything over, it's going to cause excess stress on that area. We could worry about that ICP again, but we want to try to eliminate that vagal response as well. GI, GU issues. Remember, that's going to play a factor. I think we're going to talk about it on the next slide in just a minute. Fecal impactions, bladder distension. You want to get them on a bowel schedule if possible. So using the restroom at the same time period every single day kind of gets their body on a schedule. So they'll kind of poop and pee at the exact same time every single day. Kind of gets them in their routine, hopefully to decrease the chances of constipation and a fecal impaction in that overextended bladder where they haven't been able to avoid or eliminate. Some of this may not be possible depending on the level and severity of the injury, so frequent cathing may be involved with this as well. Depending on their musculoskeletal function, we gotta make sure we frequently roll them, even go through their frequent range of motion exercises if they're not allowed to do that. So you'll do some passive range of motion to hopefully reduce the risk for contractions. Contractions are going to be pretty common with your spinal cord injury patients as well. And then temperature control. We're trying to get them in this normothermic state in the acute phase of care. Monitoring for signs and symptoms of shock. With this initial injury, we're going to have a big vasodilation response. So that's going to plummet our blood pressure. We're going to be in a very hypotensive state. So we're going to get some severe hypoperfusion. Remember, in our neurogenic shock, we're trying to get an increase in perfusion, restore that perfusion level to prevent or reduce the risk for harm. So that's where those fluids are going to come into play. That's where those vaso support is going to come into play. Blood pressure support is going to come into play with that. Other things we're going to monitor for in our spinal cord injuries or our symptoms of shock. This is a big one. Remember our autonomic dysreflexia? What are we going to see with our autonomic dysreflexia?
Severe hypertension.
Severe hypertension, all the bullet points are listed right here. So, yep, severe hypertension. What else? Nasal stuffiness. Gonna have blurred vision, poor vision, sweating, goosebumps, restlessness, severe pounding, throbbing headache. Okay. Usually that autonomic dysreflexia is going to be one of two things. It's going to be bladder distension or fecal impaction. If I relieve that stimuli, that response should go away. So make sure there's no kinks or anything. If I have a Foley catheter in place, make sure my Foley is draining appropriately as it should. Check for that fecal impaction. And this is before I treat any of this other symptoms, before I perform these symptomatic management type things. Maybe there's a sheet that's wrinkled, that's causing a pressure point. with on my skin. So if I flatten out that sheet, unwrinkle that sheet, hopefully I can get them out of this autonomic dysreflexia state, okay? Probably wouldn't do this section, okay? Patient with a traumatic brain injury becomes restless, he vomits without nausea, and has unequal pupils. Best initial nursing action. Drew says A. Everybody agree? Okay, why?
Restless.
Here, change in LOC, you have a restlessness, I have vomiting without nausea, unequal pupils. Alright, so I'm having some type of big neuro event, right? Alright, so I have an increase in that ICP. Antiemetic, maybe eventually, but that's not my priority. I don't need any type of increased IV fluids currently. I'm not trying to increase my ICP even further with bolusing fluids. Document, continue to monitor. That's just being a poor nurse. You need to do more intervention, okay? 19-year-old is admitted after a motor vehicle crash with severe TBI. Got a GCS of 6. He's withdrawing from pain, not opening his eyes, and making incomprehensible sounds. What is my priority intervention?
Better prepared.
Okay. Reassess neuro status in 15 minutes. Can I wait 15 minutes if my GCS is 6? Remember that it's a severe GCS, okay? PRN and morphine. I mean, he's not really in pain, he's withdrawing from pain, but that could actually make it probably worse. Place that patient in Trendelenburg position, increase my ICP potentially. But priority nursing intervention, airway, breathing, circulation. Maintain that airway, all right? My GCS is 6. He is not able to function appropriately, maintain like he should, okay? Patient with a T3 spinal cord injury suddenly develops severe headache, BP of 210 over 110, flush face, and nasal congestion.
C.
First nursing action.
Wow.
Everybody like C? Okay. What's he experiencing right now?
Autonomic dysreflexia.
Autonomic dysreflexia. Good. Severe sudden headache, BP super high. I have a flushed face. You have your stuffy nose, you have your drainage, your nasal congestion, however you want to categorize that. All classic symptoms of an autonomic dysreflexia. Remember, once I take away that stimuli, make sure I don't have any fecal impaction or bladder distension, so C, usually the symptoms should resolve. If they don't, then I can get some antihypertensive on board if needed. Patient with TBI has an ICP monitor in place. ICP is currently 25. What's the best nursing action?
C.
C, everybody agree? Okay, why?
Goes back to breathing.
So ICP is greater than 20, so 25. So it's not a normal finding, right? Mark that one out. Reposition head of the bed flat. Isn't that gonna increase my ICP even more? Yep, I gotta maintain that high Fowler's at least 30 degrees. Notify provider, that's a pretty good one, I like that. But encourage coughing and suctioning, that's gonna increase my ICP even more. So notify that provider, and then the hypertonic saline, remember that's gonna encourage that fluid shift to occur, hopefully decrease my ICP. Good. Questions about that? Awesome. Okay. Seizures. Big thing here is gonna be safety. What kind of safety interventions am I gonna have for seizures?
Fall,
What you said?
fall prevention.
Fall prevention, good. Patting the bed, all right. Suctioning at the bedside if I need it, okay. What else? Roll them on their side, so yeah, if we have an active seizure occurring, we can roll them on their side, right?
Medication.
Medications to stop the seizure, good. Do we stick something in their airway or in their mouth?
No,
No. Do we constrict their movements?
no.
No, let them have at it. All right. What about, let's say they're not in the bed, or they're in the bed and we have something real close to their bed. Don't we need to get all those objects out of the way?
Yeah.
Okay. So move the bedside table out of the way. All right, so they don't knock their head on that. Move the call light. Maybe there's a family member in the bed with them. Get that kind of stuff out of the way. Okay. Assessment wise, remember seizure history, what type of seizure, how long it lasts, is there anything that comes like kind of like an aura almost before the seizure occurs? Do you know if it's fixing to occur? Sometimes they get like a funny smell, kind of a weird feeling, maybe a little headache, something along those lines, blurred vision before they actually have that seizure. Then how often, how long, we've already said that. Usually they're gonna lose their bowels as well. Meds wise, the big ones that you're gonna really see are these identines right here, so if you're phosphotonin or your dilantin, okay? You're also gonna see your benzodiazepines a lot. So diazepam is gonna be a really good one, and your lorazepam is gonna be a really good one as well, or your Ativan, okay? So remember your meds, that'll be good for you. Patients with a history of epilepsy suddenly stiffens, loses consciousness, and begins tonic-clonic movements. What is the nurse's priority action?
See.
Okay. Protect the patient from injury by moving objects away. Why not insert an oral airway?
You don't put anything around.
Don't put anything in their mouth initially, right? Good. This one.
They need to protect them first.
Gotta protect them first. Good, I like it. This is a really good question. Okay. Protect the patient from injury by moving objects away. That's gonna be my priority. Then I can move on to some other things. I can get another nurse to provide that IV lorazepam for me. Remember, I'm not restraining their limbs. I'm letting them have at it till they finish off that seizure. Then if I need further intervention, if they're not able to maintain their airway, then I can insert an oral airway, protect the airway from there. Okay. Client with a history of epilepsy is admitted to the ICU for pneumonia. While on high flow oxygen, the client develops a tonic-clonic seizure. Which interventions should the nurse implement immediately? Anybody like A?
No.
Nobody likes A? I like A. It says respiratory status, change to non-rebreather if needed. What about B?
Yes.
Okay, good. What about C?
Yes.
Okay, good. Anybody like D?
No.
Alright, we're not gonna intubate them while they're having an active seizure. That'd be hard to hit a moving target, okay?
Not seeing if they do that.
I probably have seen somebody do that in the past, but, yeah, anyway, move on from that. E, anybody like E?
Yes.
Yes.
Alright, move your equipment and sharps away from the bedside, I like that. Insert an oral way to prevent tongue obstruction, remember we're not putting anything in their mouth. Then monitor for cardiac arrhythmias and hypoxemia after the seizure.
Mhm.
Yeah, we got a follow-up monitor, right? Make sure they can maintain their airway, making sure they can maintain their vitals after the seizure. Make sure they don't need any further support. Questions about seizures? Remember, it's all about safety. Safety and assessment. Airway, breathing, circulation. How do I keep my patients safe when they're having an active seizure? Alright, multiple sclerosis. Remember, this is a degenerative disorder of the CNS. So I'm gonna have increasing amount of symptoms Usually, assessment-wise, we'll have an increased amount of fatigue, spasticity of the lower extremities, gonna have frequent tremoring that's occurring. May have some tingling and numbness within the extremities, blurred vision, or double vision. That nystagmus, remember the kind of the frequent eye twitching movements. Eventually, I'm not gonna be able to control my bowels, bladder dysfunction as well, incontinence. As far as nursing interventions go, our safety precautions, what kind of safety precautions within the home should I expect?
And no slip rugs.
No slip rugs, should I have rugs at all?
No.
No, if at all possible, no slip rugs. What else?
Cord,
Cords, make sure they're up and out of the way.
fire hazard.
Fire hazards. What about bathroom safety? Good. Like what? Yep, so getting out of the shower, so have shower rails, to kind of help pull yourself up. Also your, toilet rails, bathroom rails, whatever you wanna call those, have those as well. Also make sure your stuff is within reach, so they don't have to exert a whole lot of energy. So kind of their most frequent items, make sure the remote, your cell phone, that kind of stuff's within arm's reach. Trying to maintain a high level of independence as possible. Of course, as the disease progresses, it may get to the point where they're gonna require help all the time. But I'm trying to maintain that activity of daily living as much as possible. We gotta remember and remind them to have frequent rest periods as well. They can maintain the regular exercise that they should. They're gonna get fatigued a whole lot faster than they used to. They're not trying to push through that fatigue. So we're gonna encourage frequent rest breaks, frequent rest periods during this process. That way they can kind of monitor and gauge what kind of tolerance level they have. So they can go to the mall, walk around a little bit, sit down, rest, get back up, walk around a little more, sit down, rest, have those frequent periods. Bowel and bladder training, remember again, kind of have it on schedule, have it on that clock. Questions about multiple sclerosis? Okay. Parkinson's disease. Remember, this is a depletion of dopamine. Frequent neuro status checks with this. Remember, this is gonna be that more rigidity type movements. They get up and walk. They may kind of have a pause. Where it takes them a minute, takes them a second, and eventually they can take that next step. It's kind of have that complete block or absentness right there for a moment, and they can further on as well. It's all about safety again. So remember your bed rails, your bathroom rails, frequent resting periods as well. Don't rush them through their activities. Got to be patient with these types of patients. Make sure that you use a walker. That's going to be important for these patients as well. Highly encourage that. A lot of them want to be independent and self-sufficient, and they see that walker as kind of an excess, something they don't really need. But we'll encourage that. Ladies and men, don't wear high heel shoes. Make sure you wear comfortable shoes, good walking shoes that they can walk appropriately. I know my cowboy boots out of hill long, so. That kind of stuff, okay? Promoting independence, maintain safety. Kinda all in one there. That's a good bullet point right there. You're not gonna need to know a ton about your, medications. Like I said, all about safety, teaching, prioritization on that. Remember, big ones is gonna be your carbidopa, levodopa there, okay? Myasthenia gravis, remember this autoimmune disease, progressive muscle weakness because of impaired acetylcholine receptors. It's gonna really affect your voluntary muscles. Big one with this is your respiratory status. We gotta maintain your airway, reduce that potential for aspiration risk. They're gonna have dysphagia, weakness. Like I said, most is gonna maintain to your respiratory status. Okay. Ways we're gonna diagnose is through our H&P. We're also gonna give our etiotrophium as well. We give this drug, and it's acetylcholine type of drug. It should relieve our symptoms. It's a very quick acting. It should relieve that fatigue, that weakness component of myasthenia gravis. So I should have an increase in my strength. That's gonna be a sign of a positive test. So it's gonna be a real definitive way of determining myasthenia gravis, is this tensilon or etiotrophium testing, all right? If I don't have an increase in my muscle strength, then I'm gonna look at some other options. I may not necessarily have myasthenia gravis. Big things, respiratory status, prevent aspiration risk. Which teaching points should the nurse emphasize for a patient with multiple sclerosis? Select all that apply. Anybody like A?
Yeah.
A,
Okay, so we gotta remember for our multiple sclerosis patients, what type of triggers trigger one of their events. So void hot environments can be a type of trigger. Space out activities with rest periods.
Yes.
Yep. Remember frequent resting. Use assistive devices as needed.
Yes.
Right. Walkers, canes, wheelchairs if needed. Maybe a raising recliner that kind of helps them, assist them up and out of the recliner. Okay. Avoid routine exercise to prevent fatigue.
No.
Now, we're not encouraging avoiding it altogether. Just building up a level of tolerance, figuring out their level of tolerance so they can exercise appropriately. Maintain adequate fluid and fiber intake.
yeah.
Good. Remember that bladder and bowel control, increased fluids, increased fiber can help me be regulated. Okay. Nurse is teaching about levodopa, carbidopa. Which points are essential? I know I said don't worry about medications too much, but this one's just on here.
I think A. And B.
I know for sure C.
Okay, we know for sure C, may take several weeks before improvement. Good, I like that.
D,
I'm gonna say B.
Report involuntary movements, yep, we need to report that. We need to take several weeks before improvement. It's gonna take a long time to get these carbidopa, levodopa in our system. Avoid sudden position change, doesn't really matter. Discontinue symptoms if they worsen. Remember, we're not going to discontinue abruptly with this. Okay, good. And then that should be it. Okay, and then tests and scans. Big thing, computed topography or your CT scans, remember that's gonna be for your hemorrhagic or ischemic CVAs. Can also be used in your spinal cord injuries as well to show the level of injury. Remember, if we get a CT scan, a non-contrast CT scan, and it rules out bleeding or hemorrhaging, that's when I can give my TPA for my ischemic strokes. Lumbar puncture, I can kind of rule out other types of disease processes like meningitis or something, or Guillain-Barré, that could mimic some of these types of symptoms as well. Your big things with your neuro assessment. Your changes in OSC, remember that's the most sensitive indicator of a neuro change. Pupil response, neuro response, that's affecting our cranial nerves, our grip strength, level of consciousness as far as orientation goes, pupils, are they able to move their extremities like they're supposed to, temperature control or temperature management, normothermia, usually with some type of significant neuro injury, they're gonna have a really increased high temperature, they're gonna be very hyperthermic. Pupil assessment, posturing, and your GCS scores, okay? That was quick, down and dirty. That is neuro review.
I have a question.
Yes,
Do they do non-contrast just so it doesn't mess with anything? Like
Yeah,
if there is a clot or something?
you don't want it to overall, and the CT contrast getting into that space.